Great. So we have a pretty solid group already, and I'm sure people will continue to join as we get started. But want to kick off so we have plenty of time for Dr. Maytal to go through his entire presentation and hopefully some time for Q&A at the end. But just to kind of kick things off, my name is Ashley Gans. I'm our Director of Marketing here at Forge Health. And I'm super excited to be bringing you this amazing webinar from Guy. So hopefully you guys will get a lot of really great education out of this. I know I already have looking at the presentation, so excited that he's able to share it with you all. One quick housekeeping item. The chat will be open to me, so if you have questions throughout the presentation, please feel free to drop them in the chat. And if time permits at the end, we will make sure that we get to a Q&A session where those are answered. So on that note, I will kick things over to Guy.
Great. Thank you, Ashley. Hi, can you hear me okay? Great, perfect. Let me just open the gallery. Hi, everybody. Great to meet you all. For those of you who don't know me and who I've yet to meet, I'm Dr. Guy Maytal. I'm a psychiatrist of 20 years, and I'm currently the Chief of Integrated Care and Psychiatric Services at Forge Health. And I'm also a faculty member at the Department of Psychiatry at Weill Cornell Medicine. Before coming to Forge, I was I've had a career at the interface of medicine and mental health, working especially in the domains of cancer and palliative medicine, but also with primary care and other medical specialties to help people who are dealing with severe medical illnesses and having psychological and emotional difficulties navigate their way through those challenges. So I appreciate you taking time out of your day and being here to learn together. Now, frankly, I'm completely open to questions in the middle, Ashley. If someone has a burning question, just feel free to interrupt me. It really is far more fun and interesting that way. And I do intend that there'll be plenty of time at the end for a Q&A or discussion if people are interested. Okay, so I'm going to share my screen and hopefully this works. Great. I'm assuming you can see it. Otherwise, you would tell me otherwise. Okay, cool. So here's the reason I call this sad or depressed is it will become evident in a minute. But really, this is about assessing and treating distress in patients with serious medical illness. I probably should have been more specific, although it's implied. And the capacity or ability to determine what is clinical depression or what the underlying causes of a particular episode of major depression is an important skill set to be able to have and to practice when caring for patients with medical illness. And let me just go through what we'll cover together today. So one of the first objectives is to discern the difference between how clinicians and how patients or their loved ones view medical illness and its impact on mental health. The other is to address the nuances of major depression in the setting of medical illness and to review the causes of and circumstances that underlie depressive syndromes in the medically ill and how to address them. And lastly, to give you a few ways in to address those causes in a way that's effective, clinically satisfying clinically, and makes a difference for people. So we'll talk about a case to start, because this will be largely a case-based conversation, and talk about depression and what to review some. This will be old news for almost all of you, but then talk about the limitations of the definitions of depression. And we're going to use as a marker for severe medical illness the world of cancer, because it's pretty prevalent. It's the second leading cause of death in the United States. It's also become a chronic illness for many people, as the diagnosis of even stage 4 cancers of certain types does not mean an imminent death. It could mean a life expectancy of 10 or even 20 years. And then we'll talk about thinking broadly and how to evaluate someone who is coming in with symptoms of depression, and then talk about some cases and clinical approaches, and hopefully have plenty of time for discussion at the end. So unless there are any questions, I think we should just jump on in. So we'll start with the case of Mrs. Smith, Mrs. S. So she came to see me. She's a 57-year-old married woman with metastatic liver cancer, and she has a history of emphysema. So she has an oxygen tank, and she has spinal stenosis, constriction of the passage for the spinal cord, which leaves her with significant difficulty and pain with walking. So she's in a wheelchair brought in by her husband and with the oxygen tank. And she's a practicing Catholic who participates in religious activities with some regularity. And she comes in because she was sent by her oncologist. She recently got news that her liver cancer is worsening despite ongoing treatment, and she was feeling sad and crying in her oncologist's office. And she also has a history of distant alcohol use disorder, maybe 10 to 15 years ago. And she's on several psychiatric medicines prescribed by her primary care doctor. And this is the clinical presentation for this particular person. And I invite you, just where you are, to think for yourself, what else do you need to know to start to think about how to help this person? And where do you even begin? So I'm going to leave this there kind of dangling, and we'll come back to Mrs. Smith at the very end of the conversation to see what we can now, after engage in a conversation for the next half hour or so, what we can now do to support her. So again, using cancer as a test case, distress is common, and so are actual psychiatric diagnoses, but distress is common. 1 in 3 people have some sort of emotional or mental distress. It's most common in breast cancer and head and neck cancer, actually. And it's not necessarily limited to people who have active illness or an active treatment. 1/4 of cancer survivors experience symptoms of depression. Almost half experience anxiety. And many cancer survivors experience post-traumatic stress disorder and have a significantly higher suicide rate as compared to the general population. And we could look at similar statistics for cardiovascular illness, which is the leading cause of death in the United States, although cancer is catching up pretty quickly. And the statistics really do indicate the scope of the distress across cancer population. That is a typo, but not the source of it for a particular person. And that's the bridge that we have to cross. How do you go from the world of statistics to the world of the individual? Both are valid, and the individual or the family system is what walks into our clinical spaces, be they physical or virtual. So the challenge is there's always some distress in someone who's medically ill, particularly if they're in a more acute part of their illness. It would be very weird, even worrisome, if someone was absolutely disengaged and apathetic. That would be another source of our distress. So some anxiety, some distress, some upset, it's expected. The question is, what's too much? And then what do you do when it is? What makes it significant? Well, the problem is, if it's significant, it's not just about one's feelings and emotions. It has other practical consequences. In addition, there is great evidence that when people have depression, their pain is significantly amplified. In fact, when someone has a significant pain syndrome, treating a co-occurring major depressive disorder often reduces the pain report by up to 30 or even 50%. Having psychological distress impairs people's ability to connect, to make meaning, to say goodbye when that is necessary. It also causes anguish and suffering for their loved ones who don't know how they can help. And obviously, it increases the risk of self-harm or suicide. And part of the challenge is that when someone has a severe medical illness, it means something different to that person than it often does to their clinical staff, and specifically to the medical clinicians that are taking care of them, but also to us, for those of us who are mental health providers. Again, when I talk to people who are healthcare providers, I remind them there's actually no such thing as cancer. Cancer is a kind of a meaningless term that has a lot of meaning associated with it. Because there is no cancer. There are dozens of illnesses that get lumped under this one category, each of which has different trajectories, each of which has ongoing physical and psychological and emotional concerns that may be similar or different from one another. It often starts with some symptom. There is a progression for when people have a diagnosis of cancer. It goes through diagnostic uncertainty to certainty, treatment, relapse, remission, chronicity. There's no such thing as cancer. There's not a particular thing or event with a particular end. And the challenge is that for when you and I, when we take off our clinical hats, hear the word cancer, it's often associated with death, at least an arrow pointing towards one's mortality. In fact, cancer is kind of this funny word. It's unique as far as I know, and I'm happy to hear if this is elsewhere, but it's unique because it's become the metaphor. The second definition in Merriam-Webster's dictionary for cancer is something evil or malignant that spreads and spreads destructively. So whenever in the course of human events, whenever some leader or government wants to get rid of a certain issue or group, they just label them as a cancer in society. So when someone gets this diagnosis, all of a sudden, it's not simply a biological process. It is something evil or malignant. Also, cancer has a literally thousands, like 2,000-year history of being associated with death and inevitability and rapidly dying, which, as an FYI, is actually incredibly far from the truth in our current age. This is kind of a bit of a sidebar, but it's worth knowing as someone who takes care of people that over 2/3 of people diagnosed with cancer in the United States will go into remission. Some will relapse, some will not, some will have chronic illness, but it is far, far, far from this sense of I'm going to die that it used to be. But the metaphor still remains. So all that's kind of swirling in the background when someone, whoa, why didn't that not work? Something's happening here. Huh. Well, what this was saying, there you go. Even if it doesn't point to death, any sort of illness causes significant, abrupt, and unexpected change in multiple domains. And these have to be part of what you're thinking about when someone comes in expressing some sort of issue around mood, distress, upset. There are the physical changes, the decreased ability to function, the significant fatigue or loss of strength. People's sleep is radically disrupted. The whole world of your gastrointestinal system can be disrupted, either decreased appetite or nausea or vomiting or constipation. And of course, the world of pain, either its presence or frankly, the anticipation of it. One of the things that people dealing with illness are most afraid of is having pain, even if they don't currently have it. Then, of course, there are the psychological issues that show up, the worry, the depression, the difficulty enjoying things, literally the difficulty in participating in things one used to enjoy or one currently enjoys because your body can't do it. The distress about pain, as I just mentioned, the loss of happiness, the fear, and frankly, the diminished cognition and attention that can happen either as a result of the illness itself or its treatments. And cancer, in this sort of, not to be a little tongue-in-cheek about it, is a disease that has significant social impact, which is often ignored by people's primary treaters. Cancer is really expensive. In fact, it's the leading cause of medical bankruptcy in the United States, even for people who have really good insurance. It creates caregiver burden. People who were formerly partners, spouses, children, now are caregivers. There are new roles in relationships. Maybe I was the primary earner for the family, but now I'm sick and that role has to be taken up by somebody else. Who am I now? And not to be underestimated, but often under-discussed, the decreased capacity for intimacy, affection, either because one no longer functions sexually or has sexual desire, or one is worried about one's own appearance being unappealing to one's partner or to even oneself, is incredibly impactful. And finally, the existential issues, which, if you kind of talk to people out in the world, they're often second after the physical concerns, but they're really last for most people. The questions of spirituality, of transcendence, of suffering, of religiosity. But they are to be thought of and examined. So let's kind of get back down to basics. And we'll go through this quickly because this is fundamental and foundational and familiar to all of you, I'm sure. The challenge with depression is this. It's a muddied word. Sometimes it means sad. Everyone on this call has said or heard someone say, I feel depressed today. Or ask someone, are you feeling depressed? You look kind of depressed. What you mean is sad. What you mean is a transient emotional experience of disappointment, grief, despair, discouragement, all the synonyms here. But it is something that is common, ordinary, part of being a human being, and comes and goes. Depression also means a discrete episode of low mood and neurovegetative symptoms, or a major depressive episode, something that has a beginning, a middle, and an end, and is clinically impactful in a profound or modest way, depending on what's happening with the individual. Depression could also mean a major depressive disorder, which is a relapsing, remitting syndromal illness, which means it's these episodes in major depressive disorder, the episodes of depression come and go. And especially if you've had 2 episodes of major depression, the odds of you having a third are above 90% at some point in your life. So just as a reminder, the number 2 could be a one-time thing that is related to many other potential causes. So when someone says, I feel depressed, or I've been feeling depressed, one of our primary jobs is to separate amongst these 3 and figure out what they're talking about in order to begin to be helpful. Now, this is going to be absolutely familiar to everybody here. Just as a reminder, the DSM-5 criteria for depression, 4 or more of the symptoms below, along with depressed mood or anhedonia for more than 2 weeks. Now, the challenge with the DSM diagnostic criteria for anything is that it's a threshold phenomenon, meaning you have to have 4 or more of these symptoms, these neurovegetative symptoms, plus depressed mood or anhedonia for a couple of weeks or more to get the diagnosis of a major depressive episode. So if someone only has 3 of these and depressed mood and anhedonia, they don't get the diagnosis. Does that mean they're not suffering? Does that mean they don't have some sort of syndrome? Of course not. So that's one of the challenges that we have to deal with, is that these criteria are threshold. These criteria, by the way, you may or may not know, these were created in the early 1980s by a broad-ranging committee, because the DSM was originally created not to make diagnoses. It's become, the document has become that. The DSM was created so that we can all be talking about the same thing. So that someone who says major depression in New York, Tokyo, New Delhi, London, Johannesburg, it's all pretty much talking about the same thing. Before then, there was no standardization, so we couldn't even know if we were talking about the same phenomenon. That's why, by the way, so many of the criteria for depression have to do with physical symptoms, because those can be observed objectively. The challenge is that, there are many other symptoms that go along with major depression. Here's one of the most common ones that people forget about: indecision, like the inability to make a significant decision about simple or big things, is incredibly debilitating for people with depression. It's just not on this list. It doesn't mean it's not a valid or real symptom. The challenge with medical illness is that when you're physically ill, it impacts most of these. People who are ill physically have difficulty with sleep. They have low energy. It's hard for them to focus. Their appetite's off. They may even have thoughts of death. Does that mean they have depression? That's the question to answer. Now, we'll talk, that's depression. The other syndrome to keep in mind is adjustment disorder. Unfortunately, in our work, I think adjustment disorder has become kind of a wastebasket term for anything that doesn't meet the criteria for depression, and we need to give some sort of diagnosis on in a clinical note, or to an insurance company, we give them an adjustment disorder. But adjustment disorder actually is a thing. It's actually no longer in the mood disorder category in the DSM. It's actually in the stress disorder category, where things like post-traumatic stress disorder live. Because it's a maladaptive response to some stressor that lasts for 6 months. And it has to impair your functioning, either socially or occupationally. And it's very subjective, because one of the criteria is that it's the behavioral or the emotional symptoms, they have to be in excess of what would be normally be expected, which, as you can imagine, is very culturally anchored. So what would normally be expected as a behavioral or emotional response in one part of the world or one part of the country may be distinct from that which is expected in others. So you have to be mindful of that. And there are symptoms of depression, anxiety, different behaviors. That's what's most common. But there's got to be some sort of significant stressor. Medical illness definitely counts as one of those stressors. And as I said, the challenges with medical illness is that it makes everything more complicated. The symptoms of it overlap with the symptoms of depression. The stressors could be the illness itself. It could be consequences secondary to the illness, like I have a brain tumor, but it's causing me mood changes. Or third, even the treatments that people get can cause psychological or emotional changes. So all of that is in the mix. So at the very, very beginning, the way I think about making a diagnosis of depression in people with medical illness is, if there's one thing to take away with, it's focusing on anhedonia, meaning the lack of ability to experience pleasure. If someone has anhedonia, that's a pretty good indication that depression may be happening. If someone does not, it's pretty good indication that this is not major depression. Other common symptoms include things like noncompliance, especially new noncompliance, meaning someone who was going along quite normally with their treatment plan and all of a sudden stops coming to appointments, or stops taking their medicine, or stops picking up their medicines, and the pharmacy says, hey, this person hasn't picked up their chemotherapy in 3 weeks. Is everything okay? And lastly, of course, the big one is if there's a new onset of suicidal ideation. But there are others as well. For example, pain that does not respond to treatment, or doesn't respond to appropriate treatment. That should be a kind of an hint that there may be a mood disorder happening. So what's the point of all this? Well, when someone comes in to see you with a complaint of having low mood or feeling depressed, it's really important to think pretty broadly and to include all of these things that I've touched on in your thinking. And I'm going to kind of break them down more systematically now and talk about them through the lens of several cases. So there are multiple things. These are some of them. These are the big ones to keep in mind, going from left to right, that people could be dealing with when they're having some sort of low mood or significant mood distress or even a depressive episode in the context of a severe medical illness like cancer. They could have a pre-existing psychiatric condition that's being worsened. They could be experiencing the effects of the illness or its treatment on their central nervous system. There could be something happening at the interface of their life circumstances, the medical system, the social system. There could be an existential crisis. There could be a genuine adjustment issue. There could be a crisis of faith, which is something that I think many of us overlook as a place to go. And then there are things that could look like depression and really are not, and you need to be mindful of the possibility of them so as to provide good care and avoid harming people. So let's take these one at a time. So in terms of a pre-existing psychiatric illness, here's a case of John. He's a 59-year-old man, married man. He has a history of moderate to severe major depression, and it's been well managed with stable medicines prescribed by his primary care doctor and vigorous exercise for years. That's how he manages it. He loves to exercise. He takes his antidepressant. It's worked for him for years, but now he's got stage 4 kidney cancer, renal cell carcinoma, and he's got metastases to the brain, which is unfortunately a common phenomenon with kidney cancer. And he underwent brain surgery, chemotherapy, and radiation treatment for this, and has lost 15 pounds and is pretty physically debilitated. Oh, and I overlooked to mention that years ago he had a course of psychotherapy, which he found helpful, but had till this point not seen a need to return to. So now he's coming in, he's got a low mood, and he's worrying. He's really worried about managing his depression in the setting of his cancer, because when he had it before, it was incredibly debilitating, and he doesn't want to return to that state. At the same time, the way that he has been managing it is no longer available to him. He's physically limited, both because of the weight loss surgery and pain, so he can't exercise the way he normally does or normally did. And he's kind of, in his words, kind of crawling out of his own skin, both in terms of the desire to move his body and the fear of what not doing that will lead to. So this is really a situation of leading the witness, but it really is just as a reminder that whatever psychiatric symptoms or illnesses walk in the setting of medical illness, don't assume it's caused by the medical illness. You know, some people on the medical side of things will say, of course they're depressed, they have cancer. Sadness, totally appropriate. An episode of depression is not appropriate, is not to be expected when someone is dealing with a major illness like some type of cancer. People with depression, people with anxiety, people with bipolar illness, people with schizophrenia, etc., all people who do have any sort of mental illness get medically ill. So what do? Well, you manage it as you normally would. For example, psychotherapy, medication, supportive care, whatever makes sense for that particular individual. And then continuing to encourage people to do what's worked for them in terms of wellness promoting behaviors. By the way, for a lot of people, when they're physically ill, they stop doing the things that worked well for them because the illness takes over everything. So even if they can exercise, socialize, they maybe have stopped, or maybe they're used to eating particularly well and now have stopped doing that, or maybe they've taken up alcohol at a quantity that's higher than normal, like that. So reminding them to return to or keeping an eye on wellness promoting behaviors. And finally, I think it's really important, especially in situations like this, to engage in measurement-based care. The PHQ-9 it's obviously one of the standard treatments. It's flawed for depression because it relies on the DSM-5 criteria. It's flawed for depression in medical illness because of the DSM-5 criteria, so dependent on physical symptoms, but it's good enough to track change. So it's useful to do that. So in terms of John, what we did was, first of all, just to reassure him, we increased the frequency of his appointments. And frankly, just to reassure our team, we increased the frequency of his appointments so that we could monitor his symptoms. There was actually nothing going on with him at the moment, other than worrying about depression. But we wanted to stay in close connection to him in case his symptoms worsened. And we also suggested, and he took us up on our suggestion, to start cognitive behavioral therapy so that he could have access to cognitive techniques for managing depression now that he could no longer engage in his behavioral approach of exercise. And then part of what we did was brainstormed other things he could do to stave off worsening depression, things like support groups, things like attending religious services, things like taking walks, like doing what he could do physically rather than assuming he could do nothing. So that's pre-existing psychiatric illness. Let's talk about the neuropsychiatric effects of cancer and its treatment. So Joanne is a woman in her mid-50s with 2 children, and she's got worsening multiple myeloma, which is a illness that people can live with it for quite some time. But when it starts to worsen, it can progress pretty rapidly. And she's failed several treatments for multiple myeloma and is on now third line treatment because she's failed first and second line. And she's sent to us for an assessment because she's got mood that is absolutely debilitating, totally low, and can't get out of bed. She doesn't enjoy anything in her life anymore. She can't concentrate on anything. She sleeps for 10 to 12 hours a day and is always tired. And she has no psychiatric history of significance. And her husband, who comes in with her, saying, "This is not my wife. I've never seen her like this before." That last one is actually a big clue, because a mistake would be to assume that there's something separate from the cancer or its treatment happening here. This is don't assume that all new symptoms of distress are caused by distress about the cancer. One place you always want to look and ask is, are these symptoms being caused by new medications, stopping old medications, or the cancer itself? And 2 clues are no previous mental health history and patient currently acting significantly out of character. So asking about recent medication changes or additional physical symptoms is a great way to get into that. And people will tell you that they've started new meds. They will often forget to tell you that they've stopped medicines. And it's useful to ask that explicitly because they will say, "Oh yeah, that's right. I was on that medicine and we stopped it 2 weeks ago. I'd forgotten." It's kind of out of sight, out of mind. And so this is going to help you help a lot of people who are assuming that whatever's going on is a psychological response to having illness rather than a physiologic response to part of the illness or its treatment. So in talking to this patient, turns out she was treated with interferon, which is an immunological agents that affects the immune system, suppressing the multiple myeloma. It's not a first-line treatment anymore, but she's been getting it because of her worsening disease, and that these symptoms started a few weeks after starting this medicine. this is a medicine that's known to cause significant depression in a significant subset of people. And often oncologists forget about it. Or they warn patients and the patients forget about it. So we let the oncologist know, they change the medication regimen, and using a combination of some supportive therapy and a short course of an antidepressant, she was able to return back to a pretty good level of functioning despite having this severe illness. The third aspect is the interface of life circumstances and the medical systems. You know, it's all too often we forget that we don't forget. I think the medical system forgets that social determinants of health are incredibly impactful on people's lives, including their mood. And Kevin was a 35-year-old married man, and he has a 2-year history of a moderate grade brain cancer, an astrocytoma, that chemotherapy was keeping at bay. This is becoming a semi-chronic illness for many people. However, it's incredibly debilitating. And he was referred because he was, quote unquote, depressed in his oncologist's office. Well, what turns out is he's worried about his young son and his wife. He's got a 4-year-old son. And he's underemployed. He works as a waiter in a local restaurant because he had stopped a career stopped a corporate career and was planning on attending his MBA when he was diagnosed with cancer, and figured, I'm not sure I want to spend all that money in an MBA when I don't know how much longer I have to live. At the same time, he and his wife have spent down all of their savings, about $150,000, in order to make life livable. And he's living with his in-laws and is both embarrassed about that and worried about the future. And he does enjoy time with his family, watching sports, and lives his life in persistent worry and hopelessness about what this all means, not really for him, but for his family. You know, one of the ways I think about having a major medical illness is that it's a full-time job. Being a patient is a full-time job. It's a job you didn't apply for. It's a job that not only doesn't pay you, but costs you more than you can afford in many cases, even if you have insurance. It's a job where you have no orientation, but you better darn well learn the rules of how you're supposed to behave, how you're supposed to communicate with medical providers. And it's really important to ask for help. And for many people, it's difficult. It's hard to ask for help. It's hard to acknowledge that one is less competent at certain things in life than one used to be, even recently. And for those of us who have more perfectionistic or controlling personality styles, it's particularly challenging and can even get people labeled as quote unquote difficult. The challenge for us is, frankly, the first challenge that I didn't put here is dealing with our own hopelessness. You know, I've certainly had people who come in and say, I can either pay for medications or I can pay for food, but not both. What should I do? And I'm the first person they've told that to. So dealing with our own hopelessness or sense of inability to help is really important. And at the same time, so finding and supporting their strengths, validating these are real challenges, doing our best to connect people to social resources, and frankly, talking to people about uncomfortable things, uncomfortable topics, like going on public assistance, like getting on Medicaid, like applying for long-term disability, like end-of-life issues that other folks may not talk to them about. So with Kevin, it was really about validating this is not just you. This is what it looks like to be ill, to be a patient. And we were able to connect him with a financial planner and a lawyer regarding some of the structural financial things he had yet to address. And we brainstormed ideas for low-cost ways to spend time with his family. He came up with it. He lived nearby a small local zoo, and they had a very cheap annual membership that allowed you free access. So he took his son to the zoo 4 days a week. The kid loves the zoo, never got tired of it, and he never got tired of the joy that he had. And provided support and supportive therapy as he went through this. Now, talk about three other things. One is this existential crisis, which often kind of gets a lot of top billing or attention in the cultural milieu around cancer. But it is very real for a small subset of people. I mean, most people are worried about pain, finances, other mood and emotional symptoms. How do I get through the day? And there are people who are really upset, ticked off, frustrated, or scared because it's not fair. It's just not fair. And Martha was a 71-year-old woman who's practicing Catholic, brought in by her sister for what they call depression. And she was diagnosed with ovarian cancer. She underwent surgery. Whether the surgeon said or she heard, it doesn't matter. What she heard was, "You're cured." She was elated, excited. 2 months later, new symptoms, widely metastatic illness. And she stopped everything at that point. Stopped volunteering, stopped taking walks, stopped seeing her grandchildren, and living inside of the conversation of, it shouldn't be this way, which is, in my view, one of the most human sentences that a person can utter. Because on the one hand, we all know that we have no idea how it's supposed to be, really. And we live like there's a plan. And when things don't go the way we expect them to go, it's incredibly upsetting. Part of having serious illness is constant change. It's something I call existential whiplash. There's constant, frequent changes about what you know about the illness, about the clinical course. Things were going well, now they're not going well. Things are not going well, now they're getting better. And the way the human brain makes sense of the world is through predictive models. No one here is surprised by what you see in the mirror every morning. You actually know what to expect, and there it is. You may have opinions about it, but it's there, whatever that reflection is. You also have predictive models about how your body's going to work. When you wake up in the morning, you expect certain things to happen, certain things to ache, certain things not. Your legs work or they don't, etc. But when dealing with severe illness, those things are up for change at any time. And the challenge is, we all live like we all know we're going to die, and very few of us live like that, even when you're dealing with serious illness. There is this phenomenon called middle knowledge. That's what it refers to is every time you hit a new situation, a new clinical situation, the mind decides that this is now the indefinite normal. Even though you know, if you ask the patient, they know that, yeah, this is going to keep progressing, and the outcome is going to be that I will die within 8 or 9 months because I've been told that. But they're acting as if this is going to go on forever. Often, by the way, medical teams will start to wonder, is this person in quote unquote denial? And then they might be sent for a psychological assessment or something like that. But we act as if this is a new normal. And every time something changes, we're surprised. And we know that it's going to change. That's why it's called this middle knowledge. It's both, this is going to last forever, and I know this is going to change. It's this dance back and forth and back and forth and back and forth. And how do I make sense of, how do I make meaning of this as it's happening? How do I make meaning of my own indefiniteness, transientness on this planet, now that kind of this veil of immortality is gone? You know, we are the temporary immortals. And when you're confronting a major illness, that veil tends to disappear. And most of us are unprepared for it. It's not even a problem that we're unprepared for it. It's part of being human. Most of us don't live preparing for our own deaths. And when it happens, reactions can vary from despondence to rage to dissociation to acceptance, all within one person. This is, of course, the work that was originally pioneered by Elizabeth Kubler-Ross in her seminal book on death and dying. But the stages, what we know now, these stages of death and dying, the stages of that people go through, they can happen in any order. They can change at any time, and they can go back and forth. And one of the contemporary masters of this is Irv Yalom, who is a psychiatrist and therapist who his career has been in the world of existential psychotherapy. And the clinical work is to dance. It really is a dance of where the patient is. And when they're lost in the whirlwind of emotions and changes, you don't. And it also really does require us as clinicians to have some insight into our own mortality, or at least our relationship to our own mortality, to at least have had some thoughts about it, some insight into it, so that we're not triggered or activated by things that we meet, at least not so much so that we can't be clinically effective. And really, for this particular woman, it's really about supporting her. This isn't about walking the walk for her. It's about pointing to a path. There is a specific type of psychotherapy called meaning-centered psychotherapy, or taking a meaning-centered approach based on the work of the psychoanalyst Viktor Frankl, which is effective in that it is a structured approach, either individually or in group, to address these challenges of expressing emotions around the end of life and to provide some access way to creating meaning, to make sense of it. And it involves experiential exercises, some homework, some open-ended discussions. Frankly, just the idea that just the opportunity to have someone to talk with about it that isn't terrified or annoyed or dismissive made all the difference. And at some point, she was able to return for the time that she had to some pleasurable activities. The second to last topic is a crisis of faith. Joseph was an 81-year-old observant Jewish lawyer diagnosed with stage 3 prostate cancer, and he was getting hormonal treatment for his cancer with many, many side effects, including fatigue, insomnia, and low mood. And he knew that they were caused by that, but he was still completely withdrew from life. In particular, he started avoiding his wife, which caused her a great deal of distress. And she insisted that he, quote unquote, talk to somebody, which is, of course, the great euphemism in our fields. And he, after a few visits and kind of being a little bit less guarded, he revealed that the real issues were that he could no longer be sexually intimate with his wife. And this was a great source of joy, intimacy, connection for him throughout their relationship. And he thought he was being punished by God. He didn't understand what sin he had committed, that God would allow him to live in the absence of joy and pleasure. And he was increasingly worried, as the more he thought about his own death, what would happen to him in the afterlife. Like, would he actually be able to get into heaven? And this is not a topic that we tend to engage people with, but it is central to so many people. In fact, most people organize their inner lives to some degree in religious or spiritual terms. Most people don't think about, how do I make meaning of life? Most people do have some sort of background, even if it's just when you were a child, but it becomes incredibly, it moves right front and center when you're confronting the infinite in the face of our own limited existence on the planet. And for people who have a religious connection, it can be incredibly comforting, bring peace of mind, but for others, it can cause a lot of distress. And that can lead to depressed mood, even psychosis at times. And allowing ourselves as clinicians to engage in this conversation rather than sidestepping it will allow us to get to the heart of the matter for some subset of people. Just being able to talk about it, when in certain places, we just don't talk about religious or spiritual issues in public settings unless we're with co-religionists. so as I said, simply talking about him, he was able to talk about it. I mean, frankly, he had two things. One is for a man of his generation to talk about sexual dysfunction publicly and openly was incredibly embarrassing. Secondly, there is an assumption, I think, like once you get old, you don't have sex, which is absolutely and completely untrue. And thirdly, the interface of that with his religious belief was just devastating to him. And he was finally able to talk about it with his rabbi, which is not something I could support him around, but his rabbi, just the talk to the rabbi about what he was thinking allowed him to open up and have some improvement in terms of his peace of mind and his mood and his solace. And he didn't go back to the way it was, but he really could start to engage lovingly with his wife again, which allowed them both to have some connection. And the last category is things that look like depression, things that you shouldn't miss because you're going to not treat the person appropriately or might even harm them. So, woman in her 50s, she moved to New York recently to help care for an adult developmentally delayed nephew. And she had longstanding abdominal pain. She finally got it evaluated. Turns out it's pancreatic cancer, and she's going to have surgery in less than a week. And the surgeon was wondering, she looked depressed, and he sent her for an evaluation before the surgery because he wasn't sure. So when I spoke with her, she didn't have depression at all. What she had was a long history of very heavy alcohol use, drinking a fifth of vodka every day for years, and she had proudly cut back to 2 bottles of wine a day for the previous month and was planning on stopping the day of her surgery so that she could be healthy. This is a bad idea. So a couple of things not to miss, and I'll go through them quickly so we have a few minutes for questions. Bipolar depression, always screen for a history of mania. Substance use disorders, people with serious medical illnesses, people with cancer have substance use disorders at the same rates as everybody else, if not higher sometimes, particularly certain cancers that are associated with different substances like head and neck cancers or lung cancers or liver cancers or pancreatic cancers, because they can look like depression, both stop the use of and stopping the use of. And then, of course, grief and anxiety disorders. So with Joanne, we gave her the obvious, she was not surprised. She goes, yeah, I know. The obvious diagnosis of alcohol use disorder. And rather than stopping drinking, I counseled her to continue drinking until the day of surgery, and then we'll take care of her afterwards. And when she was hospitalized, the psychiatrists in the hospital made sure that she didn't go into withdrawal. And she lived for another 2 years and never stopped drinking. This was not something she had any interest in stopping, but we were able to continue to make sure she got good care for her cancer and that things didn't get worse in terms of her alcohol use or mood. So this is what we've covered in a pretty short amount of time, and I appreciate your attention. By the way, just back to Mrs. Smith, way back at the beginning, just to wrap things up. Turns out she had a history of alcohol use disorder years ago. She had a history of depression that was actually adequately treated. She continues to engage meaningfully with her hobbies around the house, with her husband. And the depression really started with this bad news. But it wasn't about the bad news called "My cancer is getting worse." It was about a long-standing regret in the face of her own mortality. She had lived with the silent regret that she had wounded, caused harm to her children during her years of drinking alcohol. This was years ago. They're now all adults. And we really had a conversation. What was called for at that point was talking about the nature of forgiveness, like an existential conversation around what is it that you need to do now, rather than understanding something from before. And the assignment that she got was to go and have lunch with her kids and ask them for forgiveness. And she did. She came back the next time. She was like smiling ear to ear. Quote unquote, depression was gone. they had forgiven her long ago. They just never talked about it as a family. And having done so really alleviated her from that burden. So hopefully now these learning objectives have a little bit more depth and meat on the bone of them, and hope this has been of value and clinically helpful and interesting. And I would love to open it up for any questions or comments in the few minutes that we have left, which aren't many. Sorry.
Yeah, please feel free to unmute yourselves and just ask the question. You should have the ability to do that.
There's something in the chat.
There was one comment,
Yeah.
which I think is a topic that's important to discuss that you brought up, was helping to communicate with medical providers and connecting with other resources like attorneys and financial planners is typically outside of our normal roles, but could be important with this type of work.
Yeah, thank you for that. It is outside of our normal roles. And one of the lessons I learned early and often in working with people with medical illnesses, boundaries are a lot more fluid than in traditional psychotherapies. Sometimes the treatment is to call their oncologist and say, you don't know about this, or teach the patient how to communicate that in a way that's effective. Absolutely.
Is the presentation going to be available to us to like print out for our own selves?
We won't be making the actual presentation available for printing, but we will have the recording on our Forge Health YouTube page, so you can go back and reference.
Excellent. Thank you so much. Appreciate your presentation, Doctor.
You're welcome. Thank you for being here. Well, if there's, I could stop sharing my screen. There's no need. Well, if there's nothing else, thank you all again very, very much for taking time out of your day, out of your week to be here. Really appreciate being with you. Have a great rest of your day.